Good morning, everybody, and welcome to another glorious session of the ASMBS Fellow webinar. I first and foremost want to thank Dr. Dan for joining me this morning. Dr. Eckhouse unfortunately had a surgical emergency, so in his true superhero fashion, Dr. Dan is going to be joining me, so thank you, Adrian. A few announcements this morning. We are over halfway through your fellowship, so congratulations. And just a reminder to get online if you're planning on applying for the ASMBS Fellow Certificate. Take a look at the requirements, the case numbers, all of the other things that are required, and make sure you're kind of on track to get those things done. I think it's always, I tell my fellows, just go ahead and start tracking stuff now. It makes it much easier at the end of the year when you submit your application. Also, just a reminder for the annual meeting in June in Las Vegas, please plan on attending and joining us. It's a really fun meeting, and I always learn a ton. Finally, we have our happy hour, bariatric happy hour, one of our newer projects from the Bariatric Surgery Training Committee with ASMBS, where we discuss journal club articles or have experts come and display videos on certain techniques. It's always a really fun time. There are a few adult beverages consumed along the way by some, so feel free to come and join in. It's normally the fourth Thursday of the month at 8 o'clock. So with that, we will get started for today. Today, we're going to be talking about non-surgical weight loss, and we have two amazing speakers here with us today. I'd like to welcome Dr. Mary Dagen and Dr. Kevin Reavis. They are going to be talking about non-surgical weight loss. Dr. Dagen will be speaking with us about medication therapy, as well as other means of non-surgical weight loss as far as diet, exercise, etc. Dr. Reavis is going to be speaking with us about some endoscopic therapies. We'll start with Dr. Dagen, who is a board-certified family medicine physician who earned her medical degree from the American University of the Caribbean School of Medicine in St. Martin. She completed her family medicine residency at Munson Healthcare in Traverse City, Michigan. She became a diplomate of the American Board of Obesity Medicine in 2014 and has continued to pursue her passion in the treatment of obesity. She obtained additional certifications in culinary medicine and lifestyle medicine over the following years. For the past 3.5 years, she has been practicing full-time in bariatric medicine, working in a comprehensive bariatric practice and focusing on treating this complex disease. She has also had the pleasure to be involved in many community programs, including being a board member for her county health food initiatives, teaching culinary medicine in free community events, and being the team physician for a higher level hockey team. Thank you, Dr. Dagen, for joining us. Following Dr. Dagen, we'll have Dr. Kevin Reavis, who is a surgeon specializing in esophageal, foregut, and bariatric surgery. He completed his education and training at various institutions across the United States, including the University of Virginia, Vanderbilt University, and Ohio State University. He has worked as an assistant professor of surgery at the University of California, Irvine, and the Long Beach VA healthcare system, and currently works at the Oregon Clinic in Portland. Dr. Reavis is actively involved in various surgical societies, has published over 90 peer-reviewed publications and book chapters, and is interested in research and public service related to health policy, surgical device innovation, and surgical education. It is 4 a.m. where Dr. Reavis is, and so I cannot thank him enough for joining us and taking the time to do this. So we will get started. Dr. Dagen, please take it away.
Thank you so much, and thank you to everyone tuning in today. I'm excited to be the medical specialist talking to just to update some things. I feel like this is the hottest topic in medicine right now, in all specialties. So we'll kind of discuss where we're at medically treating this disease. Bear with me with technology. These are my disclosures. Today, I just kind of want to review where the current guidelines are for medical treatment of obesity, both in non-surgical patients who may not have had metabolic surgery or don't qualify, but also, of course, for those patients who are planning to or have had surgery. We'll talk about updates on current prescription therapy and talk about some future therapies that are up and coming, which are exciting. The Obesity Medical Association has been quoted as saying, weight loss does not cure obesity. Instead, it triggers adaptations that restore lost weight. I think this is a great launch point to understand where we are with the disease of obesity and our understanding, because we know we cannot cure this disease, whether it's surgical or medical. But traditionally, medically, there hasn't been a ton of data, and this has been the area that just repeatedly has not shown to have a ton of success. And now we understand why, because of all the metabolic and hormonal adaptations that really result in this disease defending itself. This disease fights back, whether we have surgery or treat it medically. But there have been quite a few advances in the medical field, and current data shows that out of the 2.2 million patients who are eligible for medication therapy, only about 1.6 of our population, 1.6% is currently being prescribed that. Obesity is a chronic disease. It's recognized as such nationally with all the major societies. And in comparison, I think the stats still show less than 1% of the population who qualify for surgery are getting surgical treatment. And obviously surgery's been around a lot longer. But if we compare that to other common chronic diseases, we know that there's still that bias and still that lack of understanding of obesity as a disease, just based on the low number of our population actually currently getting the treatment. But I don't think it's any secret that there's been a huge treatment gap prior to 2012. So really, our medical therapies have not been great. We know that lifestyle and the prescription medications that were available were not effective to make a significant difference. They were only showing about 0 to 5% weight loss. 5% can be impactful, but not significantly impactful. And then, of course, the lap band came out, which I don't think anyone is actually doing anymore. But we obviously know our surgical options are very effective to not only improve the disease of obesity, but all of the potential consequences. So rightfully so, medical has been kind of that shadow in the corner that nobody really knew what to say or what to do, or even how to educate our patients. These are the current guidelines for medical treatment of obesity. And at the base and the absolute top is still lifestyle therapy if a BMI is greater than 25. So that includes nutrition, exercise, and behavioral modifications. And I'll talk about those in a moment, but those remain the mainstay, whether a patient has had surgery or not, because we know that if we treat this disease just writing a prescription or just doing a procedure, those are the least effective options for outcomes. And if we pair it with lifestyle, it's been shown to be much more effective. But also along the same continuum, prescription medication should be considered if a BMI is greater than 27 and a patient has a consequence or a comorbidity, or if BMI is greater than 30 without that consequence. And of course, I'm sure everyone here knows the surgical guidelines. So there are about 8 different national medical organizations who all have come to a consensus that these are the guidelines, and that includes our major obesity societies, cardiology societies, and endocrine societies, particularly with prescribing for treatment. Let's talk about the food aspect first. The same data that we've been saying for many years is still true. Lowering calories by 500 to 750 a day can still achieve 1 pound of weight loss per week. So that's still the recommendation. But the question always is, what should my patients follow medically? Well, the answer is whatever they want to follow. Data continues to not support one diet over another, but really if a patient is willing to follow something, it will work. So I have a program that I have set within my practice, both for our non-surgical, but also our surgical patients. But anything a patient is willing to follow, data has supported it will actually work. So if they want to follow keto or any other fad diet at the moment, then I recommend it. But it is important to know where the current recommendations are for our post-op patients who have experienced a recurrence of obesity or a weight regain. And these are based on the clinical practice guidelines released in 2019, and that's a joint statement from a number of organizations, including the ASMBS. And these are the guidelines, and I point this out because this is often not what my surgical partners are educating patients on, which is why they get sent to me from the nutrition standpoint. So it's recommended for those 3 small meals a day to obviously chew small bites and thoroughly before swallowing, but 5 servings of fruits and veggies a day. Protein intake, of course, has to be individualized with a minimum of 60 grams per day. But it's important to note that these are actually grade D recommendations, which means that even in our patient population who has had surgery, there's no great evidence to say anyone should increase protein and continually increase protein for the best nutritional success in restarting that weight loss. So I want to just talk about the reasons for that, because this is what I've educated my own practice on. These guidelines for protein and fat intake are for the general population. So they're anywhere from 10 to 35% of our daily caloric intake should be protein, and 20 to 35% fat. You can see the breakdown for men and women. If someone is in active weight loss, they do in fact require higher protein. And of course, we have reasons for recommending high protein diets immediate post-op. But if someone is in a weight maintenance phase, or if they are medically losing weight, because it's not usually rapid, it's the same as the general population, the protein requirements. The other thing to consider is that fat recommendations. So keep in mind that in our society, most protein sources are animal products. So meat, fish, dairy. And while those products and those foods have a high level of protein, that is actually not where their calories are coming from. Most of the calories in animal products are actually coming from saturated fat, which we know is highly inflammatory and probably going to contribute to the worsening of the disease of obesity, which is also inflammatory. So since the fat intake recommendation should mostly be unsaturated, I by no means recommend that someone become a vegetarian, but we just have to be cautious about what we're recommending nutritionally in our post-op patients who have experienced a weight recurrence. So in terms of movement, this is also a big question, and there's all kinds of different studies that have been released. Should we be focusing on cardio? Should we be focusing on strength training? The guidelines from the American College of Sports Medicine, these are the guidelines from 2018, which have not been updated, still recommend 150 to 300 minutes per week of moderate to intense activity. Or if it's vigorous, it can be 75 to 150. Now, I do want to point out that the 150 is the guideline to maintain health, not to improve health. So if we're looking to improve a disease or improve our health, it really has been shown about 250 to 300 minutes is what's been beneficial. And keep in mind that is cardio. The muscle strengthening and weight training is in addition to the cardio guidelines. So if you break that down, it's about an hour a day for 5 days a week. So it's a lot of movement that's required from this category. I have a lot of people ask me about steps, and I think nowadays we have something that we're carrying that tracks every single movement that we're making, whether it's on our wrist, whether we're carrying our phone. Everybody asks me about their daily steps, and they say, well, I'm on my feet all day, so I'm getting lots of movement. So is there any value in counting steps? Data actually supports that there is. And where did this 10,000 step a day recommendation come? Well, again, these are based on the physical activity guidelines for adults, but it has in fact been shown that each increment of 2,000 steps a day up to that 10,000 is associated with 10% lower cardiovascular event rate, which is very significant. So if you have a patient that you have a starting step count of 1,000 and you can get them up to 3,000, that can make a significant impact. Whether it makes an impact in weight loss is debatable, but you can also see that for every increase of 2,000 steps a day over someone's baseline, there is an 8% yearly reduction in cardiovascular event rates in individuals specifically with impaired glucose tolerance, which we know many of our patients have. So there is value in having patients work to increase their stats that they're comfortable with, particularly with all of these things that are monitoring. But let's kind of get into the nitty gritty of everything and talk about pharmacotherapy, because again, this is kind of the hot topic of where we're at. And data does currently show that using pharmacotherapy can double or triple the odds of losing that 5 to 10% or more, and the odds of actually keeping it off and helping a patient maintain. And that is in both our surgical and our non-surgical patients. These are our current prescription medications available. They aren't robust. We don't have a ton of them. There's 9 of them. So I'm only going to talk about a few of these. So particularly, I'm not going to talk about orlistat, other than we know that this helps block fat absorption within the body. I believe I just heard that this was approved for pediatric population. I don't know that I would ever personally use this in our pediatric population, but I guess it's an option. Phentermine, I'm going to talk about in a moment, but there are some significant restrictions on phentermine depending on what state you reside in. And then we have our combination therapies and our newer therapies that have come out, the combination of bupropion and naltrexone, phentermine and topiramate, and then our SGL1 receptor agonists, liraglutide and semaglutide. So again, I'll kind of talk about those a little bit more in detail. But what you can see is happening is that treatment gap that has really left us wondering medically what we could do is starting to get filled in with more and more options and better options. So we've kind of filled in that 5 to 15%. And that can be very impactful for someone's health. And then, of course, the other surgical options I think we'll hear about in a moment. There is still a lot of question and hesitation with prescribing a medication to treat obesity. Some of that is coming from a lack of understanding of this as a disease. We still maybe think that this is a lifestyle choice, but the OMA's position on prescribing is the following. So standard of care in respect to prescriptions should be prescribed long-term, meaning short-term therapy is not appropriate. And it is medically inappropriate for licensing boards to interfere with a provider's ability to offer a standard of care. And this is really centered around using phentermine. So again, I'll talk about that more in a moment, but phentermine is the medication that's only approved, FDA approved for 3 months at a time. But the question always is, well, should we or could we use medication therapy also in our metabolic surgery patient population? So is there any data on this? The data is limited, but doing a literature review from the ASMBS, there is some data out there. And so it has been shown that our pre-op patients, it can actually help decrease perioperative risk, which I think makes sense. And it can also help those patients actually achieve their weight loss goals and comorbidity resolution post-op. It has been shown to be associated with a decreased 30-day mortality rate post-op, and that's dependent on what they lose preoperatively. However, I know there are limitations with that, where if a patient loses too much, they may not qualify for surgery. But you can see that if someone loses 0 to 5%, they can decrease that 30-day mortality risk by almost 10%. If they lose more than 10%, it lowers it by 24%. And 31% will lower it by 42%, which is, 42%. But there is some discussion about using these medications safely in post-op, which I'm personally clinically doing, and there is a small amount of data, but I also think that it is the position from the ASMBS to support the use of these medications. We know that they're very safe and effective, and so the question is, when do we start a medication? Well, of course, that it's been shown that if we start it when a patient hits their plateau before they experience that recurrence, they're going to lose more weight and actually get to that moment where they can maintain. It has not actually been shown to be statistically significant, I think, because maybe we aren't capturing that exact moment, but I do know that there is some research going on about that. There were 2 very small studies. These were both involved with less than 50 patients, looking at, does it matter what procedure a patient has had with what medication therapy might be the most effective? There's also a large amount of research happening right now to try to identify what patient in general might respond to what medication. But it has been shown in these 2 small studies that Roux-en-Y patients might be more responsive to medications that are non-GLP-1 receptor agonists, whereas gastric sleeve may be more responsive to using those the GLP-1 receptor agonists. So again, it was a small study, but something to consider, and stay tuned on further research. I want to talk about phentermine because, again, this is a topic, depending on what state you're in, there are significant regulations. In my state, we can actually prescribe this long-term, and we do prescribe it long-term because there is actually robust data. A study was published in 2019 looking at 14,000 patients that had been on long-term phentermine. It's been found to be safe and effective, non-habit forming, but again, depending on your state regulations, you may not have this option to use this long-term. The great news about this is there is a current trial going on with this medication called the LEAP trial, the long-term effectiveness of phentermine, which started in June of 2022. And it's looking at patients over the next 2 years to really look at what impact does this medication have on weight, blood pressure, and other outcomes. I'm sure cardiovascular outcomes will be in there as well. The reason that this has never been done is because this medication was released in 1959, and we didn't do long-term studies at that time. And again, because of the perception of obesity as a lifestyle choice, I don't think there was any push to do this until now. But it is exciting to know that this is ongoing, and hopefully those regulations will change to then, correspond with what the guidelines of long-term therapy are. But what's up and coming? This is why this is the hot topic in medicine. So just up and coming soon, I of course put tirzepatide up there, and I will talk about that in just a moment. But there are a number of medications in phase 2. There are some in phase 3. I actually think that there's an oral medication, an oral GLP-1 that should be released later this year based on where their trials are at. And I think there's one other one that's in phase 3 that hopefully at the end of the year will be released. I think it's another weekly injection. But look at all of these that are in development currently, and they're not just within our country. We're looking at other populations. So this list is looking at our GLP-1 receptor agonists in combination with glucagon receptor medications. We have GLP-1s paired with glucose-dependent insulinotropic receptors, and this is similar to tirzepatide. And then we have triple therapy, so targeting all 3 of those pathways. So there are 2 medications and trials. So this is a big area, and it's exciting because we're finally understanding what we actually need to target medically. But I do want to talk about tirzepatide because this, of course, is on the market currently under the name Mounjaro. It is currently only approved to treat type 2 diabetes, but of course, there are many people who are using this for weight loss nationally. My feeling is this will probably get approval and will be on the market within the next 2 months, just knowing where it was at in clinical trials. I would assume it's in the FDA's hands at this point. But this is a brand new type of medication. It's its own medication class because it's a GLP-1 receptor agonist plus that GIP component. And this kind of goes through how this works from a diabetes standpoint, because that's what it's approved for. But I think the most important data to look at is their SURMOUNT-1 trial, which is looking at tirzepatide versus placebo. And they did a titration period and then followed these patients over a year. So over 72 weeks, in this trial, the lowest dose was 5 milligrams. There's 6 doses of this medication. That is actually not the lowest dose of the med, but in this trial, that was their low dose. But just on the second out of 6 doses, it demonstrated a 15% weight loss. And the highest dose, 15 milligrams, showed a 21%. This data was actually released in September of 2022. So I don't know the final data because it has not been released, but that is astounding for a medical therapy. That's in the same treatment as a gastric sleeve. So imagine if we paired those 2. But I do also want to mention this medication. I am probably not going to say this correctly, but I'm going to do my best. So bimagrumab, this medication is fascinating, and this is, I believe, in phase 2 clinical trials. So this is a human monoclonal antibody, and it binds the activin type 2 receptors. So what that ultimately does is it affects our brown adipose tissue and can preserve lean muscle mass. So we know that this is a part of why this disease can fight back is because we lose significant muscle mass, particularly in our surgical patients. So the studies right now are being done doing a single IV dose, but it has been shown to increase lean muscle mass. It reduces body fat mass, and then it has some improvements, of course, on insulin sensitivity. When you look at this medication and compared to other medications, it's really not showing a robust weight loss, but that's not the purpose of this medication. It's more to help preserve the lean muscle mass. So there's some discussion of not only looking to finalize to see the outcome of this medication, but then of course to potentially pair it with something like a GLP-1 that could produce that significant medical weight loss, but preserve that lean muscle mass. And I would certainly think that there would be some trials done on our surgical patient population, maybe even giving this pre-op and seeing if we can improve outcomes using that. So the last thing I want to mention is Gelesis 100. This is actually not a this is a prescription, but it is not considered a medication. This is under the trade name Plenity. This is considered a medical device. But it's important to note because it is available through prescription and it's indicated for BMI greater than 25. This is actually the only prescription that is indicated for a BMI over 25. Most medications have to have a BMI of 27. But this are hydrogel capsules and they only have two components, citric acid and modified cellulose fiber. Citric acid is literally in every single thing. It's in all of our food products. It's in every single medication. So it's very unlikely that someone is going to have an allergic reaction to this. And modified cellulose is, for lack of better description, basically like chewing on a stalk of celery. But basically what these things do is patients take 3 capsules before their 2 largest meals. They have to be taken with 16 ounces of water 20 to 30 minutes before their meal. So it takes a little bit of timing. But these things get into the stomach, they get broken down and digested, and then the water basically makes them poof up and they're space fillers. So I have several patients on these, both post-surgical and non-surgical patients, and it works like the data shows. So it met the criteria for FDA approval because it achieved the 5% weight loss, and that's about what I see. Most people tolerate these rather well, except for some, bloating and things that you would expect if you're filling your stomach up with a bunch of plant fiber. So this is another option to consider for medical treatment. I should point out that data has not been done in surgical patients, so I can only speak clinically that I have safely used it in post-surgical patients. But I, as a summary, just want to show that treatment gap continues to increase with our options. And it is no longer in the 5 to 15%, but now we're spanning into where that sleeve gastrectomy is, and we're getting into the 20% or more. And so it's exciting to see all of the other options for patients that may not be appropriate surgical candidates or don't qualify for surgery. We can still make a significant improvement in this disease. So with that, I will pass over to Dr. Reavis.
Thank you so much, Dr. Dagen, for that excellent overview. If there are any questions, please put them in the Q&A, and at the end of the session, we will go over all of our questions. So please, Dr. Reavis.
Excellent. So, well, thank you very much for the opportunity to discuss endoscopic therapy for primary obesity and obesity following bariatric surgery. And thanks, Dr. Dagen, for a great talk. It'll actually dovetail very nicely, as you'll see in just a moment. I have no disclosures. I'm coming to you from Portland, Oregon, and again, it's great to be here. So, as Dr. Dagen also pointed out, there's a need for endoscopic innovation because we have 3 million candidates for bariatric surgery in this country. We service less than 7% of them, and some due to lack of access, some due to lack of coverage, and some out of fear. And frankly, many aren't up for the current options, which include basically, something akin to a Mack truck versus a small car, and really like a choice of something in between. So we're going to discuss index procedures and devices really on an evolutionary and revolutionary type of approach with endotherapeutic innovations. Evolution would that be incremental type of things, working on the current surgical platforms of restrictions such as sleeve and band, and as well as diversion such as gastric bypass. And these are revolutionary type approaches, which are just radical. It'd be manipulating type of things, neurohormonal, changing the microbiota and genetics. We'll discuss each of those. So again, dovetailing right off with Dr. Dagen, first slide is evolution of restriction of space filling. This is the Gelisys 100 that she just spoke of, and I won't continue with too much of it other than here's a photograph of, or at least an illustration of the product. And as she kind of pointed out, you swallow it, it expands to several hundred times its original size and a space filler. And with that is the restriction, hence the weight loss. Colonic enzymes break down those particles and it's passed out with the rest of stool. As she pointed out as well, is about a 5% total body weight loss. And they must be doing well because they started trading on the New York Stock Exchange last year. That's what I can say regarding that from a business model. Now, some FDA approved products, space fillers. There are 3 approved balloons in the United States currently. There's the Orbera balloon, which is a saline-filled single balloon, non-adjustable. There's the Obalon, which is 3 swallowable balloons. which break down or are passed, and then the SPAT-3 balloon, which is an adjustable balloon. The original data to basically get these approved showed that average weight loss after about 6 months was about 15 kilograms. In our series in Portland, we saw that as well, about 30 pounds at 6 months, after which the balloons are removed. In our practice, we have 6 additional months of medical weight loss counseling. There is some weight recidivism in these patients, but we try to keep that minimized with the medical programs. Patients were noted to have significant improvements in blood pressure, fasting glucose, and lipid profiles, and improvement or normalization in hemoglobin A1C. Total body weight loss in the various balloon trials include Orbera about 15%, Obalon at 7%, and SPAT-3 about 15%. So there's some differences between the various products. The SPAT and the Orbera require endoscopic placement. The Obalon can basically be done while you're wide awake, and so you essentially swallow the balloon at 3 different time periods, and that's how those 3 work. In addition to that, we also have the evolution of restriction with satiety type of devices. There's the transplant large shuttle, which got FDA approval in 2019, and the FullSense device, which is still essentially in the laboratory with gaining some impressive data, but not out on the market. So this is what the device, the transplant large shuttle, looks like when it's, well, in the lab. Is one of the engineers working with us back in 2014. And the device is basically a coil that's deployed through a device that's placed transorally. Once it coils up in the stomach, it basically forms a small ball type of thing with a tether. And you can see myself along with Dr. Rory Pryor and Santi Horgan back in, I think it was 2014, when we were working with the engineers on that device. This is on the left. You can see what the device looks like once it's coiled in the stomach with a weighted tether on the end, which then in the second illustration, you can see down in the duodenum, and essentially serves as a gastric outflow intermittent obstruction, basically a shuttle that creates a stopgap, like a valve for gastric outflow. Interestingly, it doesn't cause much in the way of nausea, but it does have an impressive amount of weight loss associated with it. Initially, some of the trials showed there's a single center non-blinded prospective trial with 20 patients. And they had 31% excess body weight loss at 3 months, and at 6 months, about 50%. There was some ulceration in 2 patients, and those devices were removed early without any major consequence. The engineers redesigned it so that there's a smoother outer covering, and that's no longer become a problem. You can see just this graph showing the improved weight loss in the transplant shuttle versus control patients, which is part of the data that got the FDA approval. Thereafter, there's not been a lot of larger studies at that point, but now that it's FDA approved, expect it to probably expand quite a bit. The FullSense device is a bit of an enigma. It's an impressive device actually coming from Michigan, where it's an endoscopic place, essentially stent with a disc at the gastric cardia that creates a sense of satiety by pushing up on the cardia. So it evokes a neurohumoral response associated with fullness, and basically causes patients to essentially feel full all the time that the device is in place and their appetite is suppressed. It augments and amplifies normal filling sensation for the stomach. Here's an antegrade view looking down the esophagus towards the esophagogastric junction. There's a retroflex view in the stomach looking back up at the GE junction, and then an outside view laparoscopic with the device in place. You can see that the improvement in weight loss was pretty tremendous. At 27 weeks, they had 75% excess body weight loss. And they basically needed to take the device out in patients. Otherwise, the weight loss just continued and continued. And so basically to halt the process before they lost too much weight, they need to remove the device. Oddly, it's been quite quiet since that initial data was presented. So we're still waiting, further results before this can go to FDA approval and become clinically available. But it's certainly promising, at least in the initial experience and what was promoted. Additional evolution and restriction of these suturing devices. The endoscopic sleeve gastroplasty has gained a lot of press lately. These devices, and there's several suturing devices that have gone kind of through the the works over the last couple of decades. Most recently, you'll hear about Overstitch. And those devices have been FDA approved for tissue apposition. So then it's basically up to the surgical endoscopist as to exactly how that is to be utilized. But again, FDA approved specifically for tissue apposition and for whatever format. 1 year mean weight loss with endoscopic sleeve gastroplasty, which is essentially a pleating of the inside of the stomach, starting at just proximal to the antrum up to the gastric cardia and fundus, has resulted in weight loss around 10 kilograms initially, and a more recent study is about 18 to 20% of total body weight loss. Again, similar to initial data with surgical approaches as well. Blood pressure was noted to significantly improve. And one of the issues seen in the initial study with Stacy Breithauer and colleagues showed that there's a release of plications in 13 of the initial 18 patients. Oddly, weight loss actually continues even with busted sutures, because there's typically a bezoar or food that forms up in the gastric fundus. So the patients end up with a jellyfish type or balloon type physiology with the foreign body sitting there, creating a sense of satiety thereafter and causing delayed gastric outflow. And so maybe a little serendipity from what the original device was, or the initial procedure was meant to accomplish. There have been some parallel efforts as well regarding endoscopic suturing procedures, such as primary obesity surgery endoluminal or POSE, also transoral gastric volume reduction or TGVR. These date back to the early 2000s up until very recent. Essentially suturing type procedures using fasteners within the stomach or sutures within the stomach, proprietary devices, essentially to create reduced gastric volume, again, similar to the endoscopic sleeve gastroplasty, with some slight modifications and similar type outcomes, some reasonable weight loss, but also some breakdown in terms of the actual fasteners or sutures pulling through over time. So we'll switch over to diversion and aspiration therapy for a moment. This was FDA approved. The initial study showed a 52-week randomized controlled trial with 207 patients with about 31% weight loss versus controls. It was effective in treating not only weight, but also hypertension, hyperlipidemia, diabetes, and fatty liver. What was also nice is that the balloons in comparison were FDA approved for BMI 30 to 40, and the Aspire or aspiration therapy was approved for BMI up to 50, which is helpful, obviously, in expanding that criteria. Unfortunately, due to economic factors, it was withdrawn from the market last April. And the company specifies this is not due to safety or lack of good outcome. It was really just the economic pressures of the pandemic, et cetera. So stay tuned. This may return in some future format. Moving on to diversion, other diversion type of devices. EndoBarrier is a device that's deployed at the level of the pylorus and extends a couple of feet down into the proximal small bowel. I was a part of the study back in 2014, and it looks very simple in theory, but in practice, it's a somewhat complex deployment procedure. But it worked well, particularly in treating diabetes. Now, they originally engineered and redesigned targeting a device that would be something just for a couple of months, but folks were really interested in about a 1 year treatment. The engineers were able to accomplish that, but there were a lot of challenges along the way. The 1 year data revealed some substantial weight loss and improvement in diabetes, and they enjoyed a substantial improvement in hemoglobin A1C levels, and it was probably likely due to those Roux-en-Y similarities. The differentiation between EndoBarrier and some of the other devices was the metabolic crossover. And really to capitalize on kind of those dual effects, the marketing really targeted diabetes as opposed to weight loss initially. And it was originally marketed more metabolic and for diabetic treatment as opposed to weight loss, and how it got its FDA approval for pivotal trial. The meta-analysis showed that excess weight loss dropped in about 12.5% compared to diet alone. And in 2014, we were part of the Endo trial I mentioned. It was terminated during the interim analysis because there were 7 cases of hepatic abscesses forming in patients, basically because the anchors of the device were quite assertive and were creating issues outside the lumen of the bowel. It's now undergoing re-engineering of that anchoring system, and so we may see it again in future studies. Just a quick note on the Lentex, which many of you may have heard about. It's another type of liner actually implanted surgically at the esophagogastric junction, bypasses the stomach and small bowel for quite a ways, and got a lot of attention back in the early 2000s. They raised $33 million in about the first 15 years and about $50 million by around 2018. And investors, quote, hope that this would not take another 15 years, end quote. And things got really quiet after 2018. So there's not really much going on that I've been able to see in that time frame. But there's a lot of excitement, like I said, there. So we'll have to see if the future holds much there. Now, kind of a take on, instead of implanting a device, is actually just changing the entire surface milieu of the duodenum, would be duodenal resurfacing. This is a company called Fractal, and it involves taking a water-filled balloon, heating it up to 80 degrees centigrade, and essentially ablating the duodenal mucosa, which sounds a bit morbid, but it works. There's a 1 to 2% reduction in hemoglobin A1C and a single center small case series, and led to basically an FDA investigational device exemption to initiate a U.S. Clinical trial. Press release just a couple of weeks ago showed that it is now available in Germany, and they've shown some improvements, as I point out, really for improvement in diabetes and insulin management versus weight loss, because it's essentially focusing just on the duodenum there. Another flip side of duodenal ablation would be duodenal coverage, and this is with glycine. It's a coating agent. So this is a duodenal applied mucoadhesive polymer. It's soluble in the gastric pH and then precipitates into a solid, basically, film in the duodenum. Initial studies were done in rodents, and that it was applied through a surgical access. Obviously, ideally, it would be placed endoscopically in humans. In 2022, they got clearance from the U.S. FDA as an investigational new drug, and then have had some success in improvement of basically blood sugar metabolism in initial animal studies. Next up is diversion using magnets. And so there's a couple of companies that are pioneering this technology. For the most part, have investigational device exemptions from the FDA. And you can see here an endoscope with a magnet, which is being deployed through the scope type of device. And then in the second illustration, you can see a different type of one, which is deployed externally from an endoscope with a second magnet on the opposite side. The way these have been designed has typically been with a colonoscope plus an upper endoscope, where the upper endoscopist will be able to proceed down through the esophagus, stomach, duodenum into the jejunum, and the colonoscopist is proceeding up through the colon into the ileum. So it requires some talent for sure. And typical procedure times have ranged anywhere between 30 to 40 minutes up to a couple of hours, and discussing these with colleagues. And so with each of these technologies, you have to think to yourself, well, laparoscopically, how long might it take to do a jejunal ileal anastomosis, which would pretty reliably be less than an hour. And so the lack of invasiveness of the endoscopic and colonoscopic approach, although attractive, we need to take into consideration the talent required actually to maneuver into those positions. In 10 patients, the average BMI of 41, patients were classified as diabetic and pre-diabetic. They had substantial improvements in their hemoglobin A1C as well, dropping from 7.8 down to 6, and improvement in fasting blood glucose as well, with excess weight loss around 28 pounds. Again, these aren't designed as much for weight loss as for improvement in diabetic control. And because it's not a complete bypass, it's going to be, again, a partial response compared to something like a Roux-en-Y gastric bypass. Another company, Magnimosis, has these quarter or coin-sized magnets, which are deployed, as you can see in the third illustration, one proximally and one distally, not actually in the colon the way the illustration shows, but actually in the distal ileum. And they have an investigational device exemption from the FDA as well, and starting clinical trials along those lines. And then exciting coming from Michel Gagne and colleagues at GT Metabolic, which is another company involved in magnets and typical therapies, like I described before. I think there's a workshop coming up before SAGES and later this month that should be exciting. And anyway, keep that name in mind. It'll be interesting to see upcoming data from then as things progress. And then a kind of a twist on this is the physio type of diversion. That is this Statosphere device. It's a duodenal implantable device with a nitinol backing with multiple spheres that basically cause a punitive reaction within the duodenum, decreasing motility and altering hormonal signaling back and glucose metabolism. I'm not sure I would have thought of this independently. So you have to sometimes think absolutely outside the box. In 31 patients with an average BMI, they had improvement in weight. Unfortunately, there was device migration in about half of those patients that needs to be re-engineered, emergency surgery in 2 of those patients. And they had about 3 times the weight loss compared to control in, again, small study that was done with improvement in insulin secretion and glucagon, like peptide 1 kinetics. That is not FDA approved and, again, still within the lab. So we'll have to see how that progresses down the pathway. And then another kind of twist on reality would be feces to the rescue. And then there have been some studies showing that lean patients, both in rat studies and in human studies, that lean individuals typically have more diverse range of bacteria in their feces compared to obese individuals. And so the thought is, would a fecal transplant of someone with the microbiota of a thin individual or a lean individual into an obese individual actually result in improvement in weight? There's some promising data there. That's a bit beyond the scope of today's talk, but something certainly to pay attention to because it's in the lay press, and I mean, your patients will be asking me about that. And so then, just to finish up with some thoughts on revisional surgery, and this is where I think Dr. Dagen's presentation really is helpful, because it's where I certainly rely on some treatment augmentation as well, and you'll see why in just a moment. So back in the late 2000s, StomaFix, coming from Endogastric Solutions, was a device that was released, and essentially is a transoral device with a kind of vacuum tip, sucks in tissue down at either the gastric pouch and the gastric bypass or the actual stoma itself, and then fires these H fasteners. You can see a couple of those on the table there in that first photograph, essentially reducing the size of the pouch or reducing the size of the stoma. And only 22% of patients achieve the goal of 15% excess weight loss, which was not that much over their goal to begin with. And so that trial was actually terminated early for failure to accomplish those goals. You can see in the illustration on the right, just in theory, how plicating the pouch and stoma reduces the size. Another one, restorative obesity surgery into luminal, the ROSE device and procedure, is a proprietary endoscope, which fires these fasteners, which basically have these nitinol nets on either side with kind of an H fastener going across, similar type of approach as the StomaFix, with reduction of the stoma or the gastric pouch itself. There was a small trial with 20 patients after having a weight regain of about 13 kilograms, and at 3 months, those patients have lost 8.8 kilograms on average. However, 3 months is only 3 months. So the durability of that really is what's called into question, because as we know with human anatomy, typically things will acclimate and stretch over time. And so that is certainly something of concern going forward. Overstitch is the surgical device that is probably most commonly utilized now in terms of stoma reduction or gastric pouch reduction by going essentially plicating, again, a gastric pouch or stoma. It's also used for patients who have refractory marginal ulcers from time to time, and oversewing those with some success in small case series. I think the lesson, though, is that multifactorial etiologies exist for weight gain, much beyond just pouch and stoma dilation, and you really need a multidisciplinary approach to address this going forward with, I think, lifestyle, pharmacotherapy, as Dr. Dagen had illustrated, as well as a potential role for endoscopy. But I think the durability of those techniques is something that needs to be further followed out. Results are typically temporary, and insurance typically doesn't cover for these. So oftentimes this is a self-pay type of situation for patients. The final thoughts. Endoscopic therapy for obesity. We're evolving from using current surgical principles that have, again, restrictions such as band and sleeve, and diversion, that being gastric bypass, and revolutionizing things with physiologic concepts, beyond just the mechanical, and thinking about the neurohumoral feedback loops and addressing those. FDA has given full approval for things like balloons and transport shuttle, as well as the suturing devices. Others are still on the pathway with exciting times to come. And again, I think it's important to remember that weight gain is multifactorial and needs to be addressed in a multidisciplinary fashion, so that we can show impact on the disease, and that thus facilitates progress. Thank you.
Thank you, Dr. Reavis. That was great. And I'm going to have to brush up on my principles of transplant skills now that we're going to be doing fecal transplants for obesity. I have some comments and some questions that I'd like both you guys to weigh in on. And I apologize if some of these are comments, things I think about. The question I get asked the most in the doctor's lounge by my residents, my peers, is, are you worried? With all these great new GLP-1 receptor agonists, GIP-1 combinations. And I think the fellows on the call are probably also not necessarily worried, but wondering. I'm getting into a specialty here where there's a huge there are huge advances in the medical therapy for obesity. And my answer to them, and not just my answer, but I think our entire society and our entire specialty is really embracing the fact that we actually now have some help and some multimodality capabilities to treat obesity, not just surgically, but also medically, and also obviously with behavioral modification, the three major prongs. So don't be worried. This is probably going to bring in more patients. I'm already seeing people who are trying these medications. But Dr. Dagen, my first questions for you, and just your general thoughts on the following. First of all, we see some pretty awesome results, not just for medical therapy, but also for the full sense device. You look at 70% excess body weight loss. That should pique everybody's interest. But we have to also remember that those are in patients with different indications where maybe their excess weight loss was 20 to 30 pounds. It's not that hard to get to that. So that's different. How will these medications play a role in the long term? So that's number one. The other thing I want you to comment on is these medications. What happens once you stop them? Do they actually change the set point of the patient in terms of their obesity? And we also got recent data that from the Splendid trial that shows that the prevention of cancer in patients with obesity is actually dose dependent, and these medications may not get us that prevention, whereas cardiometabolic diabetes, sleep apnea, and such, they may improve. Other things, side effects, cost, they're pretty expensive too. We may reach the time when the insurance company says, no, go get your bariatric operation because we're not paying for this for the rest of your life. So things to chat about. What are your thoughts on that?
Yeah, thank you. Those are great questions, and all very common questions I get from community members, my colleagues, and my patients every day. There is this question. I think I work for a big practice. I have multiple surgical partners as well, and there's been some concern, oh my goodness, what's going to happen surgically? I work for a large hospital system, so we're having these discussions. The reality is this is just going to open up therapy and open up the doors for people to understand this as a disease better and better. There's been a fear of surgery for many reasons, but I think the biggest reason I hear is because everybody knows someone who has experienced a weight recurrence. But again, we think that means the surgery is failing. It just means we haven't understood the disease, right? So I think as we educate our community, which is going to take a long time, it's going to really open the doors for both treatments and to work in a collaborative approach. And that's what we do in our hospital system. So I don't think anybody's going anywhere. I, in fact, think that it's going to make everybody busier. And I think that's exciting because more and more people will want to seek treatment. I'm going to speak to the, I think there was a question on limitations on medications and when should you use medications and who can't you use medications in. The biggest things to think about, phentermine, for example, cannot be used in AFib or someone who has coronary artery disease. And Topomax, the only time I really don't use Topomax is number one, if a woman is in childbearing years and they are not on birth control, or their partner has not had other sterilization methods. But if someone has had a history of obstructing renal stones, I probably won't use it. Keep in mind, obesity in itself increases the risk of kidney stones pretty significantly. So there's no reason to not use it in someone who has just been found to have a kidney stone or had one episode. And there, I see that there was a question on gastroparesis with GLP-1s. I absolutely do use it in those patients. And because I find that many times I'm not totally clear how that diagnosis even got in the chart or if they truly have gastroparesis. So if it's been documented, I'll use it cautiously, or I may involve the provider who had made that diagnosis and get their opinion. But it's been the opinion of my colleagues that it's safe to try. And I've had minimal side effects or any issues with gastroparesis with GLP-1s.
But Dr. Dagen, they are known to cause decreased motility, right?
So they decrease gastric emptying.
Right.
So that is part of what they do, yes. But clinically, have I experienced worsening of that? No, not necessarily. And specifically on things like semaglutide, there's no necessary warning that says you cannot use it in that patient population. In terms of cost, just to put it out there, my health system is one and the same as Priority Health. So I have lots of discussions about costs of these medications. I clearly do not set the cost of these, but I think that, I think the cost is limiting. I work in a state that Medicaid covers these medications, which is amazing. There's only 13 states that have that coverage. And I hope that particularly as this gains more national momentum, companies will recognize the importance of putting that investment in. I know there's data that supports bariatric surgery, I think pays for itself within 2 years, but I think that data has yet to come, of course. So the question then is, how long do I have to stay on these medications? Well, my answer to that is however long it takes to get to that goal that we're working towards, and then you have to add at least a year. Data does support that all those metabolic changes that happen that make that disease fight back persist for a year or longer, regardless of whether or not someone experiences a weight recurrence. So meaning ghrelin goes up, all the satiety hormones go down, metabolism goes down, and even with weight regain. So I usually recommend that patients stay on this for however long it takes to get to their goal, or the goal that we set, plus at least a year. But the reality is there's a reason that these meds are approved long-term. And I feel that this is no different than treating hypertension. If you treat hypertension and it's controlled with a medication, our society does not expect to come off of that medication ever, nor do they question it. And that's kind of the approach that I take. This is a chronic disease. It's the most prevalent chronic disease in our country. So we should be treating it the same. Oh, you're muted.
Great. Thank you so much. What happens when you stop these medications?
Yeah, that's the big topic on NPR and all these discussions, right? So keep in mind, I think we all know that the media doesn't cover the full story. So I think some of this information is coming from twofold. Obviously, when semaglutide was released, the company made an awesome decision to allow a 6-month coverage with a copay card. And it didn't matter what insurance you had, meaning Priority Health members could also have access to this medication for 6 months. Unfortunately, we know that, as I just demonstrated, that the data does not support that this disease metabolically is even going to be controlled at that point. So coming off of a medication too soon is going to promote weight recurrence, probably plus some. And I apologize. Ask me what you, go back to your question.
Oh, just what happens? Is there going to be a rebound? Is there going to be a greater than expected rebound, possibly decreased, basal energy rates, anything that could potentially change that may harm the patient when we stop it?
Yeah, I think that the data that I'm seeing is, based on other trials, we know that the decrease in metabolic rate is significantly greater than what we anticipated in all the studies. And I don't think it will be any different with this. And I think that's the reason for looking at some of these other therapies, using combination therapies. and just targeting different pathways. So if a patient comes off of a medication, do I anticipate they're going to experience a weight recurrence? My answer is I think it depends on where they are in their journey. I think that they could potentially come off of it. We do know that the body can develop a new lower set point, but the question, I have not seen any data of how long does that actually take? When do these metabolic changes stop and be happy at a lower set point? So I again maintain that I think patients should start understanding and providers should start understanding this is a long-term disease. And again, whether it's surgical or medical, we don't cure this disease. That's why that collaborative approach is so important.
I love it. And I think patients and clinicians need to understand that. And even more importantly, insurance companies need to understand
Yes,
it.
I'm working on it.
They allow us to use, medicine and surgery and use them together.
Yeah.
Question for Dr. Reavis. Gosh, I like to think I'm a young guy. I'm no longer a young guy. I've been around for a couple decades here. I remember in my fellowship, people were talking about the endoscopic sleeve and the endo stitch and all kinds of developments. It's been 20 years, Dr. Reavis. I think these novel approaches have to contend with the truly excellent outcomes that we see with surgical therapy, especially sleeve gastrectomy, where the perioperative complications should be very, very, very low. Do you think that's been the rate limiting factor? What is limiting these devices and these procedures from really revolutionizing metabolic surgery?
Yeah, great question. I think rather than looking at it as kind of a failure of the endoscopic arena, maybe a success of the laparoscopic arena. When surgery was, and it wasn't too long ago, I was a resident rounding on patients who had open gastric bypass, and they're in the hospital mandatory 7 to 10 days. Those days are gone. And I remember still controversial comments about having a gastric bypass patient go home at 24, 36 hours, which is now, very, very commonplace. And so it's hard to contend with those outstanding numbers. And I think that has a lot to do with it. I think the endoscopic suturing components, physically separating the tissues with sleeve gastrectomy and gastric bypass, as we found in the past, in trauma, when you do a duodenal exclusion, it's going to open back up again. We know that. And so doing things and hoping they stay kind of stuck together for decades at a time, I think is short-sighted. That being said, again, there's the serendipity that even with the sutures that have, come loose in the vertical sleeve gastroplasties or endoscopic sleeve gastroplasties, and they still continue to lose weight because of the unexpected kind of food retention up in the gastric fundus, I think, is impressive and something kind of to take note of. But what it's led to more is probably like the success of like the transpyloric shuttle, and the fact that the balloons are absolutely non-invasive. They basically go in and go out without major tissue manipulation, I think is a good thing. I think endoscopic tissue manipulation, where you're actually trying to bring things together and oppose it definitively, unless you're actually definitively separating things and then putting them back together in an anastomotic fashion, is not going to play long term. And the implantable devices, I think, just like the medications, they're temporary. And so when those balloons come out, when the transpyloric shuttles and such come out, there needs to be another plan in place. And I think that's how we have to frame it, as opposed to thinking, oh, this is going to take over surgery. surgery is here for a reason, because it is, a step, it's definitive, and then you're done. At least, for the foreseeable future. Obviously, you need to, survey for, potential revision, that type of thing. Whereas I think the endoscopic and the therapeutic therapies are going to be those that are maintenance and are going to require continued follow-up, and maybe even switch from one to the next, just like the medical field, where you're going to have, some meds patients respond to, and then there's certain, medications that patients don't respond to, and so I have to move to something different.
Thank you so much, both of you. Those were fantastic lectures. I think, we can't emphasize multimodal therapy enough. And so this has been really, I've learned so much and have a lot to think about now for the future, as I even add some of these things into my practice. So thank you both very much. We appreciate your time, and we look forward to the West Coast Q&A session.
All right, we'll see you a little later.
Thank you.
Thank you, Dr. Reavis and Dr. Dagen. We truly enjoyed your lectures, and for the sake of time, we're going to jump into some of the questions that the fellows are posting on the chat box. And first question is for you, Kevin. They're asking about the future of the endoscopic sleeve gastroplasty. You said there's a lot of enthusiasm, and it's becoming common practice in many places. Do you think the future of the ESG would be similar to the future of the sleeve plication?
Well, I mean, I think first, thanks again for inviting me to speak. It's been a lot of fun. In terms of endoscopic sleeve gastroplasty, it has an advantage over, lap plication in the fact that, it's incisionless. And so there's a certain attractiveness to, in terms of patients regarding that. Given the similarity, I think, of just gastric plication versus sleeve gastrectomy and both requiring a surgical approach, I imagine those are going to, I think, for the most part right now, sleeve is more popular appropriately and has better outcomes from that perspective. I think endoscopic sleeve gastroplasty, until it's widely covered by, say, Medicare, it's going to be, for the most part, not covered by insurance. It's going to be a self-pay type of option. I think, which is fine. I mean, there's a market for that as well. And I think the outcomes are going to be kind of what's been shown so far. We have great surgeons that are, suturing, and they still bust, but they end up with this kind of bezoar up in the fundus, creating this, kind of a delayed outflow type of early satiety and some weight loss, which again is serendipitous because that's not really the way the whole thing was supposed to play out. So I think it'll be interesting to follow. I think as long as there's a market for incisionless procedures, there's going to be a population that will move to that. Obviously, those that are dependent on insurance coverage will stay with formal surgery. And as the medications are covered by insurance, Dr. Dagen's, influence will be that much greater as well.
Yeah, I mean, Kevin, while we're talking about the ESGs, I don't personally do any primary ESGs, but we've done a few ESGs on high-risk patients who had a sleeve and are gaining weight and have evidence of sleeve dilatation on upper GIs and endoscopies. So my question for you, how do you select your patients? Like when you have somebody, do you go by BMI, or is it like an insurance coverage issue? If they can pay out of pocket, you would go for an ESG first, and then if that doesn't work, we'll do something a little bit more invasive, or you go by BMI?
So, I mean, full disclosure, I'm still actually morphing into endoscopic sleeve gastroplasty myself, because I've been with laparoscopic sleeve gastrectomy all along. I do have a couple of fellows that we've trained that have gone on to do more of that. It does seem to be in the lower BMI groups that do that. And I think just, mainly because if you look at the relative weight loss, it's just less. So I think it's going to be really patient directed. And again, the fact that it's not apples and apples. This is a covered benefit, typically with sleeve gastrectomy, and an uncovered benefit, typically with endoscopic approach. And until we've got just a real foolproof, absolutely durable endoscopic way of doing this, I will, probably lean for the most part towards, laparoscopy, unless a patient is, really, really interested in that endoscopic approach. In terms of higher risk, lower risk, there's still risk of leakage, with endoscopic procedures, because, ideally you're going to get full thickness purchase of the stomach. There have been splenic injuries and hepatic injuries, and et cetera, as well. So although it looks attractive from that perspective, there's still some surgical risk associated with it. So I don't know if I would categorize a patient's higher risk going towards endoscopy and lower risk going towards laparoscopy. Having those 5 points of laparoscopic access is certainly helpful. Endoscopic surgery, when we're doing POEM, et cetera, is sometimes nerve-wracking because you got one coaxial working port. And if you get into trouble, you got one coaxial working port as opposed to multiple angles to deal with something.
I really want to bring Dr. Dagen in to the conversation as well, because I think she raised some really important issues with the medications for patients, and that's also crucial. There are a couple questions in the chat from me as well, too. But first I want to ask, How, as a surgeon, would you recommend, or I guess what I should say is, how would you recommend that a surgeon go about starting to put their patients on these medications, especially for patients who have regained weight? Is it something that the surgeon can start prescribing? Do they need special credentialing to do it? How do you recommend that?
Yeah, that's a great question, and I'll echo what Dr. Reavis said. Thank you so much for having me and letting me be a part of this. I absolutely think surgeons can start these patients on medications. Anyone can actually start them on it. You just have to have the education on when to use them, what meds to use. It's always a challenge with insurance, of course, but I work in a collaborative team with our surgeons. We're all in the same practice and we have a medical team. So sometimes the surgical team will get the patient started on them and then refer over to us just so they don't have to wait for that initial consult. But I absolutely think if they're comfortable doing that, it's really about their comfort. My surgery colleagues, in terms of maybe the surgeons and not the APPs, prefer that our team do that. They're just more comfortable with that aspect, but our APPs are a little bit more aggressive. They've taken some more education on, and they honestly message me about it if they have a question and say, hey, can you review the chart? Can you see what would be appropriate? So I think having a medical component, I believe is now a national recommendation for continuing accreditation as well, if a program is accredited, to have someone on board to work with that medical. But absolutely, they can start it.
Mary, there's a question about the use of GLP-1 agonists for weight regain or weight recurrence after a sleeve or a bypass. And when those patients hit the plateau, when do you start the GLP-1 agonist? Is there a magic number do you go by? I know the definition is all over the place.
Yeah.
Recently there was a published position statement talking about the definition of weight recurrence or weight regain, and they're pushing for us not to use recidivism, and they also covered the different definitions of weight regain. Which definition do you go by, and what's the magic number do you use to start anti-obesity medication for those patients? And what's your preference? Do you start with GLP-1 agonist, maybe phentermine? I know you talked about phentermine. Can you give us like a quick rundown of what's your approach from a practical standpoint?
Yeah, so I'm typically seeing, at least the way our practice works, whether the patient had surgery within our practice or at another facility, I'm usually getting them when they've already experienced that weight regain or the weight recurrence. And so I think it's the challenge is, when do we know that they're at that plateau versus kind of just settling into that point where they might maintain for a year before experiencing that regain. But I think I'm generally speaking, with any surgical or non-surgical patient, I give my patients about a 5 to 10 pound window, where if they go past that, we need to be more aggressive. So if I see a 10-pound weight gain, then something we're doing isn't working. So at that point, we need to either reconsider medications or add a medication if it's not already on board. And in terms of what I choose to use first, again, I have to look at health history. So I'm the one managing kind of all the other consequences and comorbidities of obesity. So if the patient has diabetes, for example, I may use a GLP-1 that may not be specific to obesity or the GLP and GIP combo. But phentermine in my state is also not as strictly regulated as it is in many. So depending on insurance coverage, such as Priority Health and Medicare, who do not cover GLP-1s, then I may start them on phentermine if they don't have a contraindication, because I find that that's a great starting point if a patient can tolerate it.
There's a great question here for Dr. Reavis, asking, about the longevity of treatment for patients who have obesity. So we know that obesity is a lifelong problem. How is it that the short-term treatments that you're talking about, ESG, the endoluminal barriers, et cetera, how is it that those short-term treatments can actually cause long-term effects in patients? And how do you explain that?
Yeah, actually, and I'll dovetail this into being a question for both of us, because the short answer is it's got to be a bridge. There's got to be a long-term plan. The VSG and endoscopic sleeve gastroplasty is supposed to be durable. It just isn't. But some of those sutures do hold, and there is, some longer activity and benefit with that. But the obvious ones, the balloons, the other two, the transpyloric shuttle and the balloons, go in for 6 months, they come out. yeah, there definitely needs to be a backup plan. I think philosophically the idea was, we'll bridge them, from dangerously high BMI down to where they'd be appropriate surgical candidates. Of course, the FDA approval for balloons with BMI 30 to 40, not exactly that high risk group that you think of. The market is frankly different than I expect. I kind of expected balloon patients to be my typical bariatric patients. They're not. They actually typically come through other type of clinics, aesthetic clinics, etc. And they're in between Atkins diet and Jenny Craig and balloon and liposuction and down the line. It's a very, very different philosophy. It really kind of surprised me. But absolutely, a 6-month weight loss plan is very, very short term. And as Dr. Dagen kind of pointed out in her talk, there are insurance companies that cover these medications for 6 months. And you'd never expect an insurance company to cover insulin for 6 months or an antihypertensive for 6 months. So I'll let her kind of follow that as well. Medicine and these endoscopic therapies need to be part of a much broader, again, comprehensive approach.
Yeah, and I'll echo that. I can't echo enough the collaborative approach, whether it's with a medical bariatrician or your local primary care offices who might have some expertise in these medications. But I think we know, surgery's been around a lot longer and it's been consistent, whereas the medication part has not. But I think that is the part that's changing, and that's a little bit unique. But it absolutely has to be combined, either or. I refer plenty of patients over to my surgical partners if appropriate, and vice versa. But I do think having kind of that same approach with some of these shorter term procedures and helping patients understand this as the disease that it is, that this is not going to cure this disease, but it's a long-term plan that might include medications when you hit that plateau. And we want to get those on board sooner rather than later. So the same thing as was mentioned before.
Very good. Thank you so much. I think we're going over time, but I truly enjoyed that discussion and the presentations. Again, on behalf of ASMBS and the training committee, we thank both of you for your time, your expertise, and this nice discussion. Have a good weekend, everyone. And again, thank you so much. And I'm hoping that the fellows learned something today.
Great. Thank you.
Thank you.
Guys.
Bye.